I remember early in the visiting scheme, going into a unit, a small unit, and them saying, at the end of the day, after we'd had all of these accounts and accounts of this type, and with very little to offer them, and they said, thank you for coming. We thought we were alone. We thought we were doing it.
Try having a drink, Professor. Take your time.
Help me about what the matron said about the scale of death that they had observed in that unit.
Yeah, and this is one of those things that is really very difficult to capture in figures. The scale of death experienced by the intensive care teams during COVID was unlike anything they had ever seen before. They're no strangers to death. They are the intensive care unit. They look after some of the sickest patients in the hospital. But the scale of death was truly, truly astounding. I went into this and other hospitals where they said it would be routine to see 3 to 5 deaths a day. I worked on a shift where we had 6 deaths in a single shift. Another hospital told us that they had 10 deaths in a shift, 2 of whom were their own staff. We had nurses talking about patients raining from the sky, where the nurses said that one of the nurses told me that they just got tired of putting people in body bags. Another hospital where they said that sometimes they were so overwhelmed that they were putting patients in body bags, lifting them from the bed, putting them on the floor, putting another patient in that bed straight away because there wasn't time. We went to another unit where things got so bad, they were so short of resource that they ran out of body bags, and they were instead issued with 9-foot clear plastic sacks and cable ties. And those nurses talk about being really traumatized by that because they had recurring nightmares about feeling like they were just throwing bodies away. These people are used to seeing death, but not on that scale and not like that. And whatever the figures show you, the experience for them was indescribable. And when we talk about capacity in healthcare systems, the toll on those teams from that scale, and it really was like nothing else I have ever seen, and certainly not like nothing else those teams had ever seen in their experience. It was incredibly difficult.
I can see it's taken its toll on you. You are, I dare say, no stranger to death either in your 26 years of experience. Why is even recounting this now so obviously painful for you, Professor?
I've never seen anything like this on any given day. I have served in a clinical role in several major incidents. I was on the scene of the Soho bombing in 1999. I worked in the emergency department during the 7th of July suicide bombings. I have attended a number of very serious civilian major incidents in my time with the Helicopter Emergency Medical Service. And nothing that I saw during all of those events was as bad as really COVID was every single day for every single one of these hospitals throughout the pandemic surges. It's painful now because it was very clear what was happening to the patients. It was very clear what was happening to the staff. The staff were very injured by just how overwhelmed they were by the whole thing.
Do you think the patients were getting the care that they needed?
They were getting the best care that could be delivered. I've said already that intensive care is about the detail. Once you start diluting the detail, it kind of stops being intensive care. It's really hard to describe this, and this is why I think these visits were important. Whatever you read in the columns on the Excel spreadsheets and the data didn't tell you this, and it didn't tell you about the actuality of the thing. And for the smaller hospitals, the thing that I described of transferring patients out to try and create capacity, What it meant for the smaller hospitals was that they were drowning in patients. The bigger hospitals would come in, try and relieve that pressure by transferring patients out. When you come in, you transfer patients out. You transfer out the most stable patients because they're the people who are most likely to be able to survive on more limited equipment in a moving vehicle for several hours if necessary. But what that meant for the smaller units was that they were left with a cohort of patients that were most likely to die. And for the smaller units, when we talk about the scale of death, over the next few weeks, those units would experience a mortality rate of in excess of 70% in some cases. 7 out of 10 of every patient that they had died. And I remember early in the visiting scheme, going into a unit, a small unit, and them saying, at the end of the day, after we'd had all of these accounts and accounts of this type, and with very little to offer them, and they said, thank you for coming. We thought we were alone. We thought we were doing it.
Try having a drink, Professor. Take your time.
They said, thank you for coming. We thought we were alone. We thought we were doing it wrong. And I just thought, how have we left them feeling like this? How has no one told them that this is not their fault, that it is the surge that has come with COVID that has led this to happen? But if you're a unit and you're isolated in that way, how can you know that it's not you? You watch 7 of every 10 patients die. How can you know? And so, those experiences basically affirmed for me the need for the visits and the need to try and get this information up.